Hey, good morning, everyone. It is C.W. Hall, your host here on the Health Executive Roundtable. Thanks for making us a part of your day today. I know that you don't have to watch TV very long to be seeing news stories right now about the opioid crisis. It's obviously being discussed in the highest levels of the U.S. government, trying to come up with a solution for what is obviously becoming a pretty significant epidemic. I'm sure most, if not all of us sitting here at this table probably know somebody close to us who may have dealt with an issue around opioids, whether they were taking them for a short period of time and were surprised to find that their body actually kind of grabbed on to that medication being on their body, even in a short period of time. I myself have known a family friend who dealt with an opioid addiction themselves that was born out of an undiagnosed spinal injury. So it affects many, many people, and I'm very pleased to have our panel here. We have Dr. Ellen Shaver, a neurosurgeon out of Augusta. We have representative from the Georgia House, Beth Beskins, with us today. Dr. Doug Lundy, a trauma surgeon from Resurgence Orthopedics. Nicholas Smith from the Attorney General's Office, Director of External Affairs. Donald Palmisano, one of our regulars on the show from the Medical Association of Georgia. And then my colleague here, Don O'Neill from CopernicusMD, a wide range of perspectives, and we'll be looking to each to kind of get their thoughts on this. And Ellen, let's start with you. Talk about the scale of what we're talking about here.
Well, this is a crisis that we've never really seen the size of before. Currently, the statistics are that 140 patients have overdoses a day. In the past year, that's resulted in 30,000 deaths, which has quadrupled since 2010. The financial burden is enormous. There's estimates of $55 billion being spent each year, as well as $20 billion in emergencies and hospitals.
Well, truly significant, and I'm very pleased to be bringing these types of perspectives together, so hopefully we can maybe start some momentum towards swinging that curve. From the perspective of somebody who's dealing with those patients, I heard you two physicians speaking here before we went on the air today about, how it starts for many people. They have an injury, oftentimes either musculoskeletal, in your case, Dr. Lundy, where they had some pretty severe trauma, and of course, same for you working on folks with spinal injuries. Talk about it from the perspective of that acute phase and how you kind of conceptualize the approach to opioids in those patients, because they're probably going to need some measure of pretty strong analgesia.
Yeah, that's a great point, CW. I mean, one of the big things that we have to deal with, specifically in the realm of injury, and I'm an orthopedic trauma surgeon, is that the people that present to us have legitimate and real causes for the pain that they're having. It's not that they come in seeking any type of substance or anything. They've got real live fractures and other types of injury that are significant pain generators, and unfortunately, narcotics are the only, and opioid prescriptions are the only ways that we can really effectively manage a lot of this pain that a lot of these folks have. Part of the issue, however, is that a fair number of people come in already with addiction issues of some type or the other, and then, of course, their injury is not going to help that at all, and so they take a problem that's initially come on and make it a lot worse with not only because they've got a significant pain generator, but the best, not the only, but the best method to alleviate acute pain after injury is the use of opioids, which tend to only make their confounding issue worse.
Yeah, and I'm curious how you approach that from the perspective of just the engagement phase of the patient, telling them how when it comes to how do you take these and how long do you need to take them, should you take them. I remember back when I was in the hospital long ago working at the bedside where we would talk about taking the pain medicine before it really starts to hurt again. I'm curious now, today, what is the philosophy on that? Because back in those days, we were educated as clinicians trying to manage pain to try to prevent that crescendo of pain, because once you get to that place, then it's difficult to combat that post-surgical or post-trauma pain. What is the perspective on that now?
Well, certainly we don't want patients to be in pain, and if they are undergoing a large surgery, they are going to have acute pain. But the issue is pain is a very nebulous characteristic, and so you can do the same two surgeries on the same surgery on two different patients, and one patient is going to request pain medicine every 4 hours, and the other person is going to take maybe 1 or 2 doses, and then they won't need it anymore. And part of it is what Dr. Lundy has been talking about. If they come in with a baseline level of addiction or chronic pain medication usage, it's certainly going to be higher.
I'm curious from the perspective of that type of discussion, the case where a person turns out to be somebody who may, when they present to you with these injuries or with this source of pain that is legitimate, it's something around either a skeletal injury or other trauma, and they need it. But you talked about occasionally you'll run into folks who are dealing with some measure of pre-exposure, if you will, to either opioids or some similar substance that affects that pathway. How does that come through? I mean, I would imagine that there are some folks that are reticent to reveal that in their history. I mean, maybe some do, but talk about that. Does it begin to reveal itself through that acute phase of I can't get their pain under control, and that's how you kind of begin to maybe question, is this something you've dealt with in the past, like with the patient from an addiction type perspective?
Well, if you take a patient who, say they've been in a car accident, so they're hospitalized, and it's very easy to tell who has a prior addiction. Their pain level is constantly at a very high level. They're constantly asking for pain medicine. They know the exact dosage they're getting. They know the exact dosage that they want. And those patients, we have to sort of take a step back and say, are we treating their pain, or are we treating the euphoria that they're getting with the pain medication?
Well, Dr. Lundy, how did we get here? I mean, that's one of the things that we talk about is, from a pain perspective, is like what brought us here with the physicians, the pain management, to the point where we went from maybe 15 years ago that people believed that opioids were not as addictive as morphine, to where we are now, where we're seeing 80% of the world's prescriptions are being consumed in the United States. You talk a little bit of like what led us up to this crisis and how did we get here?
That's a fantastic question. I have a certain framework on that. I do a lot of work in the developing world, in Africa and Asia, where these narcotics and these opioids are not available for patients. And it's always amazing to me how you can do rather significant operations on people. There's a significant change in their paradigm to where they expect there to be pain. They just want to be made more comfortable. And I think that that's a fallacy in our culture, that you have this huge operation, you shouldn't have pain. Well, that's not reasonable. We endeavor to make you comfortable, but completely removing pain is certainly not the right way to go about it. I think there was a multiplicity of things that got us to where we are now. Specifically, and I don't think there was any vast conspiracy that drove us there, but I think that, of course, as we're all familiar with pain as the fifth vital sign, that we were all pushed as physicians that we weren't appropriately addressing pain. Remember when we had the long-acting oxycodone and other types of morphine substances that had the 12-hour or even longer releases, and how we were told that many times by pharma that this is less addictive and you don't have to worry about the tolerance issues coming on, because as long as you're treating them for pain that's real, and you don't have to worry about that. And we were pushed in many ways of that. I'm on the board of the Orthopedic Trauma Association, and interestingly, we're getting a lot of pushback now, back all the way from HCAP scores, that some of our members are being negatively affected from a compensation standpoint from the systems that they work in, because their HCAP scores are lower. So they feel, I need to do what I have to do, but my patient population by default is not that happy, and so I need to, and pain management's one of those. And so we're pushed in many ways to try to reduce this as much as it can. And then, of course, we get a lot of push from patients as well, and certainly a lot of it can also fall on us. I don't want to make sure that we're not part of the issue as well. A lot of times that it's the easiest thing to do is just to give people what they want, rather than have a long discussion about why they didn't have it. So I don't think there's one specific point in the play of how we got here. It's a multiplicity of things, and I think we're all to some degree complicit in it.
So from a state perspective, Representative Beskin, I mean, obviously it's impacting economically. We have impacts as far, there really is no demographic that's untouched in this, from ranges of income, employment, demographics as far as race, religion. It doesn't matter. There's no discretion when it comes to how this addiction gets chosen. Give us some ideas from the state level, like how is legislatively? How are we trying to combat this? Or maybe you can share with us maybe some ideas or some platforms from a state level of, where does the state stand on this?
Thank you for that question, Don. This year, Georgia General Assembly passed and the governor signed into law our bill, the PDMP bill, and I think 25 states passed that last year, so I did some work on this summer. I think 49 states now have a PDMP, the Physician Drug Monitoring Program, which is the first step towards physicians reporting who they've prescribed drugs for, which will help to prevent patients from doctor shopping. And that's not the only application of the PDMP, and it's going to be phased in next year, and we have to make sure that that works. Also, we worked and passed a bill this year about further regulating pain treatment centers. And we did pass a bill, which I voted against and the governor vetoed, which would have expanded the number of opioid prescribers to include physician assistants. And there was so much perception that with a problem being oversupply of opioids in the population, it's not a good idea to increase the number of prescribers. With all that said, looking around at what other states have done, it's very interesting that veterinarians prescribe opioids. And we do not currently require veterinarians to report to the PDMP, yet many states do. Our neighboring state of South Carolina, for example, does. Mm-hmm. There's a very interesting story in the news today that in this year's Iditarod, 4 of the dogs on the second place team tested positive for tramadol. So, and if you research back, the 1968 Kentucky Derby winner, a horse named Dancer's Image, won the Kentucky Derby and was ultimately disqualified for testing positive for phenylbutazol, something. I've got it written down here. I'm not a physician. So looking at requiring veterinarians to report, because people take their pet medications, and there have been reported cases of people harming their pets in order to get that prescription. And a few others, but I know that others here will be speaking about elimination. Whatever we can do on the state level of elimination of pain is the 5th vital sign, because physicians will tell you pain is a symptom and not a sign.
It's amazing when you think about what you just stated, which is from a veterinary perspective. I don't think anyone that is in the general population would think, wow, there's people that are taking their dog's medication. And it sounds ridiculous, but it really is the same drug, just in a different delivery method or maybe a different dosage. But it still drives the same result. Am I right, doctors?
That's right.
I mean, and so I don't think a lot of people think about that. And obviously, thanks for that. And I had the pleasure of being at the Opioid State Task Force, which you spoke at, which I think you're obviously very passionate about this, and we certainly appreciate that. One of the things that you had talked about with PDMP was the fact that it's not state to state.
That's right. There are some states that are moving toward sharing information with PDMP from state to state. We didn't address that in our PDMP bill this year, but clearly, like I know Dr. Shaver practices in Augusta, where if a patient can't get an opioid prescription from her clinic, they may go right across the state and fill that prescription in South Carolina. So patients don't stop with their prescriptions at the state lines, and there would be a lot of merit to allowing interstate sharing of PDMP data.
One of the things, and obviously, Mr. Smith, thanks for joining us from the Attorney General's office. Can you give us an idea of, from a law enforcement perspective, what's being done, maybe some initiatives at the state level from the Attorney General's office? I know you obviously are probably joined with tons of joint task force that are trying to combat this problem at the illicit level, but can you share with us maybe some things that the Attorney General, like some things the Attorney General focuses on, or there's some priorities with this?
Well, definitely. And as you know, thank you for attending the task force. Upon appointment from the governor last year, Chris Carr, once he was appointed, we kind of took our internal assessment of, how our office is involved in the opioid crisis. As you know, we represent all the executive agencies and some of the licensing board, for example, the pharmacy board. And we have a very interesting role there with some of my clients, such as the GBI, Georgia Drugs and Narcotics. And what we found out was that it extends much farther than that. In terms of the statewide opioid task force, what Attorney General wanted to do was create this infrastructure of communication with the private sector, the nonprofit sector, and pretty much chambers of commerce or anyone this issue touches to kind of get the issue out there and serve as a sounding board to see, what is currently being done around this issue, and if there are any gaps, how can we fill them? And so we kicked that off last month, October 4th. We had our first initial meeting. And from there, we've learned a good bit of things that are being done around in terms of the pharmacy benefit programs. We learned just a few weeks ago, we joined a letter encouraging other pharmacies to adopt policies such as CVS has put out with eliminating the 7-day prescriptions and encouraging more services programs that kind of move towards the non-addictive programs when it comes to prescribing. So those are some things that we're starting to see there and that we're kind of been involved with.
Are there anything that is, I'm sure there are, but what are some of the things that you're doing from an intervention standpoint? I mean, obviously when CW and I have had multiple discussions about this, knowing people who are in the grips of addiction, it's not the rational thinking person that does the things that they do to acquire these drugs, whether it's in an illicit manner or doctor shopping, whatever it may be. Are there some state initiatives to intervene rather than, in just log jamming the criminal system to actually help some people get help so they can get back in their right mind and kind of break the addictive cycle?
Yes, we've been hearing things of that, but from our office's standpoint, we serve more as a support system from the perspective of the Attorney General's office. I know there's been some talks within the General Assembly with Senator Ellerman and others who are considering legislation to kind of move towards those initiatives. But from our office's perspective, it's more so of a support and sounding board group.
It was just this week. I think I sent you the notice. I got a alert on Monday that I think it's Fulton County that is beginning to legally take action against opioid distributors. And then last week, and then I think it may have run again this week, there was a 60 Minutes discussion actually talking about that at the distributor level, where obviously they're a necessary component of that logistics chain, but apparently there was some measure of question with some legitimacy behind it as to how effectively are they managing where they're sending their medications. I think one of the examples that they used was a small town of less than 500 people that was dispensing hundreds of thousands, if not millions, of opioid pills, things like that. I'm curious, is there going to be, you think, more action like that from a legal perspective, either county and state?
I do think there will be more legal action like that. In terms of the distributors go, we have not filed a suit. However, we are still investigating the facts and just seeing what's out there. But as far as the manufacturers go, through our Consumer Protection Unit, we are part of a multi-state investigation where we are, as I said, still learning the facts. And we have also sent letters encouraging some pharmaceutical companies such as Purdue Pharma, Tefla, Cephalon, and trying to see if there was some malpractice or unlawful practices with that. So that's what the Attorney General has wanted to kind of become involved in, and not necessarily go ahead and file a suit, but just to learn and see if there were some type of unlawful practices, and from there see what we should do moving forward.
So from a legislative perspective, obviously there's a lot of facets involved. Obviously you have the manufacturer, you have distributors, we've got physicians, and first of all, Mr. Palmisano, thanks for joining us. Obviously representing the Medical Association of Georgia, you are a powerful arm in a lot of things that happen in the state, but can you, give us an idea of how this has impacted the physician and the level of care, like for example, PDMP. What's the physician's impact? What's the stance from the organization that represents these physicians with regards to, number one, the law that they're currently under, and maybe are there any ideas or efforts that are coming from your side, from the physician side, to kind of attack this problem?
There's a couple of things. And first of all, thank you all for this opportunity. Thank Copernicus and CW and all for having this forum, because this issue, you can go on for hours and hours about this issue because we have yet to find that solution, as evidenced by the number of deaths that are still occurring. I would say this, that the Medical Association of Georgia and the MAG Foundation, we've been addressing this issue since 2010. We supported the original Prescription Drug Monitoring Program bill that passed back in 2011, I believe it passed, didn't go into effect until a couple years later. And so we worked on that bill. I think one of the things that really, in House Bill 249 that passed this last General Assembly, one of the most important pieces of that was to move the Prescription Drug Monitoring Program out of Georgia Drug and Narcotics over to Department of Public Health. And that's significant for a number of reasons. When you talk about, we were one of 4 states that still had our PDMP being housed and being controlled by a law enforcement agency. In my prior life, when I was practicing law in Louisiana, I did a lot of insurance fraud. When I would deal with insurance fraud adjusters, they were very limited in their scope and in their views on what they were going for whenever we were looking into a fraud case. Not every case was a fraud case, right? And so when you deal with a general adjuster, they had a bit of a more general view. And I think that's what public health is going to bring, because public health doesn't have that law enforcement approach. It seems to be more of let's aggregate the data and see where the troubled areas are. And it's not a knock on law enforcement. It's just that's how you're trained. So if you're trained one way, you're going to look at things one way. And then if you're trained another way, you're going to look at them another way. So that, I think, was very important that came out of the law last year. As it regards the PDMP, we've always supported physicians checking the PDMP. We agreed with the registration piece this year, so the physicians all have to register by January of 2018, but it doesn't go into they don't start checking until July, and it's scheduled to opioids along with benzos. So when you looked at it, and we just had our House of Delegates this past weekend, we've been pushing this information out, and 58% of the physicians had already registered. 27% were going to register that had attended our House of Delegates. About 64% understand the law, so there's still an education piece that needs to get out there. But here's what we found was really interesting. How does the PDMP and the workflow into their practices? So some states have been recognized as having a very good PDMP, such as Massachusetts. And the reason being is that in their state, what happens is when the physician opens up their EHR, the PDMP information is there. It's connected to their EHR. It's not a separate portal. In Georgia, it's a separate portal, okay? That's a challenge because the physicians then have to leave their electronic medical record, go into a portal, and then check that portal. Now, the issue is this. APRIS does the technology. The technology is already there to do it. It's just a budgetary piece. So in order to make it easier for the physicians, when they have to jump into a portal, it takes 4 minutes when they go into that portal to check the PDMP. And so then they have to get back out and keep logging back in. It's it doesn't fit into the workflow. However, if you put that into the EHR and into their medical record, what will happen is that it goes down to less than 30 seconds to check it. Now, there's a $1.5 million budget piece to it, but that would make our PDMP, instead of being on the lower end and being viewed by some of the physicians as kind of clunky, to being as to one of the premier prescription drug monitoring programs. So I think that issue really needs to be addressed by the General Assembly. I think it's, people have an understanding, they just hear PDMP and they think all PDMPs are the same. And that's not true. So I think that's one of the issues that really needs to be worked on. The other thing I'd like to address is that we've been in this debate for 7 years and listening to it. And what I find interesting, we're now blaming pharmaceuticals are involved, the doctors are involved, distributors are involved. I'm not hearing about the payers and the insurance companies paying for treatments. I'm not hearing about addressing other modalities. What about cognitive behavioral therapy? What about some of the non-addictive medications that are put on lower tiers? Why? Because opioids are cheaper. And so that's where a lot of this goes, is that it's cheaper and it's easier to pay for, right? Well, what about the psychological side of addiction and addressing that? Or when somebody goes into a multimodality treatment center, and not having multiple co-pays for the psychological side, the behavioral therapy side, and what have you. So that's what I really think needs to be addressed, and we're encouraging legislation for whoever would be interested in doing that, that would mandate that payers and really come to the plate on this, because we all have a piece of this problem that we've got to find the solution. So I hope that becomes part of it, because right now everybody is trying to do broad-based solutions that are impacting all patients versus going after the spectrum of patients that are having the addictive issues. And so when you start limiting the number of days that a physician can write, what is that patient going to do in a rural area that has to drive 60 miles to see that physician, pay a copay, then get their medication for 7 days? And what if they have to come back? What is that patient going to do? And I think that's not really being taken into account, because we all want to do what's right. But I think that it's what you're doing is fantastic with the Attorney General bringing everybody together, because that is what's sorely needed. And we've done it through our foundation, but I think that's very important, and I think that's how we get to solutions. And then you hear the unintended consequences of, oh, patients got to drive now so many miles, they don't have doctors in their area. So just keep that in mind as you kind of go through this process as well.
It's funny you brought that up, and CW had that conversation. Ironically, Dr. Shaver and I had this conversation recently, which is there's an incentive at the payer level to keep people on opioids, as you just said. Some of the alternative treatments for pain management, which would be shots, or there's a lot of alternative therapies out there, but they're expensive. For example, the average patient, treating for back pain, the payer will pay for 3 shots in a year. Well, that's 3 months. What do you do for the rest of the year? Yeah. Well, if you're on opioids, it's a cheaper solution. And from our perspective, and again, I think I say our perspective, I think one of the problems that I recognize and that we recognize is it seems like that the attack or the front that's being taken right now that it's addressing the issue is focusing a lot on physicians. Mm-hmm. And I disagree with that wholeheartedly, and I'm going to present it to the panel with this question to all of you. I think we have, for the first time in the history of our country, an illicit drug problem that has a single point of distribution. We don't have 3 million pills being smuggled across the border from Mexico. We don't have pills coming from Canada. We don't have people cooking oxycodone pills in their bathtub. And so we have a single point of distribution that we know where the pills are coming from. We know where they're being pressed. We know how they're being distributed. And to focus on just the physician and saying, hey, you guys are the problem because you're prescribing it. Well, there's so many exogenous factors involved in how something is prescribed, whether it's acute or chronic pain, whether you have someone who came in your office that's already at 900 or 1,000 milligrams of oxycodone a month, and are you going to threaten their health by reducing that and causing them to be in withdrawal symptoms? But I think from a solution standpoint, I've always felt like we've got the answer in front of us, because for the first time, we're not really worried about, hey, how did that guy on the street corner get the 60 oxycodone tablets he has in his baggie in his pocket? We know where he got it. He got it from a pharmacy. And there's a single point of distribution where that chain comes directly to. So is there anybody here that's involved in or have seen, what are some of the options of focusing on that distribution point as a solution to the problem? And I'll start with any of the panel. I mean, Dr. Lundy or Representative Beskin. What are your thoughts on that?
I think your question started with, and rightly so, who else here besides physicians can be called upon to solve this problem and decrease the prevalence of opioids in our society? The PDMP focuses on prescribers reporting, and so we're talking about the distribution chain or the role of the patient in behavior, personal and external behavioral modifications to keep people from becoming addicted to substances. One that doesn't have to do with physicians, and we're moving towards this, and we could pass some legislation, but entities are voluntarily moving towards drug drop-off boxes. And I have a note here, is October 28th Drug Take-Back Day, so that's coming up
this Saturday.
This Saturday. So I know that CVS has an initiative that they're going to put these boxes, drop boxes, in 750 more locations, but that's less than 10% of their locations. Some already have it. We could possibly pass legislation to provide immunity for hosts of those boxes, because just like bank robbers want to go to banks because that's where the money is, drug addicts would want to go to these boxes and maybe steal the whole thing, because you don't know what all's in there. It's kind of like the ultimate grab bag. Right. So drug drop-off points is one thought. And I know that Fulton County, I think Mr. Smith mentioned this, I think Fulton County, we're in Fulton County here, has indicated 2 days ago they're going to file suit against distributors. And the Attorney General is looking at multi-district litigation against the manufacturers.
Sure. And Don,
I'm sorry, go ahead.
And Don and CW, actually, some initiatives that we actually done yesterday, we were actually out in Fulton County at one of the Walgreens location actually promoting Drug Take Back Day. When you talk to a lot of people in general, they've never actually heard of Drug Take Back Day, and the thought of it can actually be scary, because it's, hey, we've got these drugs, come into the store and bring them back. Oh, you're going to arrest me. But and you hear that often, but in terms of raising awareness, I think that it is very important to get out the word. And Attorney General Carr actually at the end of this week, we'll be making various stops around the state just to kind of promote the issue, and we're encouraging everyone to get out. And if you have some drugs in your cabinet, let's practice safe measures and dispose of them, because last year we had 982 deaths of overdose in the state of Georgia, and if you can save one life, that's a step forward.
I think there's a couple of issues on this as well. So one of the things, if you look at the people that are taking these, they're getting it through one of two channels. They're getting them legitimately from their prescriber. The physician's actually writing it to them, and we should probably look into those issues to find out what is it about those patients or those prescribers that they're continuing to provide this patient with this extraordinary dose of opioids that eventually ended up in them overdosing and or even dying from overdose on this. The other one is the diversion to where I believe that this patient needs this or whatever, and I'm prescribing it to them, and then they're diverting the drugs into a system where they're being purchased on an illicit manner from there. I haven't really seen any extensive research on these issues so that we as physicians know the difference and can recognize what's in there, because we think we're good at it and we try to be really good at it. But one of the other big problems with it, and Donald brought this up earlier, excuse me, is the difference between the chronic pain patients and the efforts of trying to reduce the prescription to 7 days. And to Donald's previous point about the unintended consequences, there is a significant problem with this in the multiply injured and the patient with significant injuries or significant surgery. 7 days isn't enough. And to say, well, because we have this side issue or these people are taking too many opioids, we're trying to reduce the volume on the street, and so by definition we have to decrease the amount that you can have, that doesn't resonate with the person with multiple injuries from multiple extremities, who's got spine injuries, pelvis, abdominal injuries, pulmonary injuries. They're laying there. They finally got them home because we were trying to get them out of skilled nursing facilities, and now somehow they got to manage to get to CVS every 7 days for their that's throwing the baby out with the bathwater. That's not a small movement of the thermostat. That's flipping it all the way to the other end. Well, so we need to make intelligent and reasonable changes in law and rules, not just say, let's just radically change everything because this is clearly all the problem.
Dr. Palmer,
and also to point out with the drug take back, one of the things that our MAG Foundation was doing, we got a grant from the Medical Center Foundation up in Northeast Georgia, and we provided drop boxes as well as naloxone for that 13 to 14 county area over the course of the last few years. The positive side of it, we were actually able to measure when law enforcement saved a life. We know that over 60 lives were saved with Narcan. But you're right, a lot of the drugs come from people taking them from medicine cabinets, from their relatives, from their friends, things like that. And it's one of the challenges with the drug boxes is that you have to put them where there's some sort of law enforcement. Now you can put them in pharmacies with changes that were made at the local level. Mm-hmm. But I think addressing the liability issue would encourage probably some of the independent pharmacies to be able to do it, because that's one of the challenges right now. You can get them into some of the chain pharmacies because that's available and they have the staff working there, the employees to deal with it. But the bigger issue is how do you get into the independent pharmacies that are in some of the rural areas, because they are the pharmacy. So that was one of the challenges that we saw. And also on campuses now, we were able to put them on Georgia State's campus, Morehouse's campus, number of campuses around through a grant that we received from Kaiser Permanente. So they've been fantastic to work with. So, some of the hospitals, but also like a Kaiser Permanente really stepped up in working with us to try to address this issue.
But one of the points, just to clarify, is the reason for having the drug drop boxes is so that people who aren't intended to take the medications aren't able to get them. Mm-hmm. And one of the points that Representative Beskin brought up at the task force meeting was trying to avoid giving narcotics to children or patients under 21. And maybe you want to say a word about that.
Some other states have moved towards that, have passed legislation to prohibit most prescriptions of opioids to minors. I mean, anecdotal reports would tell you that I think an addiction specialist, Dr. Blank here in the metro area, has said that if someone is not addicted to a substance by the time they're 21, chances are good they will never be during their adult life. So keeping opioids from being prescribed for minors, and the biggest portal of entry for addiction with minors is either wisdom teeth surgery or an injury like a skateboard injury where they present to the ER. And so I know that people, for example, Children's Healthcare of Atlanta would be opposed to that because for children who have cancer or a chronic condition, opioids are necessary. But from a patient's perspective and a parent's perspective, always, ask for something else first, something else besides an opioid. One other potential legislative idea that doesn't involve physicians that I think would help would be allowing, and other states do this, allowing the partial filling of a prescription. So say you walk out of Dr. Lundy or Dr. Shaver's office with a prescription for 50 pills, but that person goes to the pharmacy and says, I don't think I need 50 and I don't want 40 hanging around in my cabinet. Let's just get 10 now, but they would still have an open prescription for that other 40. So that would be an easy thing that I think might help.
And if I would just jump in on this real quick, I would be, just from the Medical Association of Georgia's perspective, you just want to be careful that the state is not getting into the medical decision-making process of the physicians and of the dentist and whoever else that this may impact. Because when you start setting the standard of care within statute, I think that you start getting to a slippery slope of it's opioids today, what is it going to be tomorrow, the next issue? And so that's just some hesitation that I would caution.
I would agree with that, and I am aware of that.
I think
you.
the partial
Mr. Palmer.
filling, though, that's a fantastic idea because, to our point, we want to make sure they have enough. But
Right.
if they can, that's a great point because that gets the stuff out of the medicine cabinet, so there's nothing there to steal.
And then the patient would not have to go back to the physician to get another prescription. They would still have the open prescription up to the maximum of the initial prescription.
One of the things I've heard us talking about today with the PDMP is, again, the distribution piece, right? It's trying to interrupt the distribution flow at the prescriber level. It would seem that that's kind of the place. You got to have a prescription to get the medication. And I think there's good thought behind that. I'm curious because I don't know from my position kind of outside the clinical realm anymore, but when you go into the PDMP, the doctors here in your office, and you're looking to see if Charles can have a prescription for pain medicine, it shows you if someone else, another colleague, has relatively recently or when they had previously prescribed pain meds for me, correct?
Yes.
It's filled. It's when it's filled. Yeah.
So when I go then to my pharmacist, because I know I take some Claritin D these days, and I can't get Claritin D without my ID and something that they can check to see, you've had 90 milligrams in less than 2 weeks, so you can't have your antihistamine just yet. Does that also then communicate if you've made your entry that you've prescribed me medicine? Does my pharmacist see that? Do you follow me with that at the pharmacy level where I'm actually picking up the med?
Only if you go to the same pharmacy where you had the prescription filled previously. They have their own records.
Well, that's one of the things that I'm thinking about as I've been listening to all of these great perspectives today. Is that one, through work I do outside of here, I'm aware that there are now biomarkers available that will tell me before I prescribe you this medication, in this case opioids, but it can be other types of medication. I can tell you that this particular medicine won't be effective for you because the gene that makes the enzyme for it won't be produced by your body. We need to do something else. I know that is true for opioids, and I don't believe that is yet being very heavily adopted yet in the prescription process. There are islands of it here and there, but not very heavily utilized just yet to determine how will you process opioids if I give them to you. Beyond that, it would seem to me that there's got to be something that, from a biomarker perspective, technology perspective, that knows when I walk in, just like I go to get my antihistamine, that I don't get to pick up medicine because it knows it's me and it knows I just got a prescription filled across the street. Do you follow me?
Well, right now, the best that the pharmacies can do is use patient data, your license, your insurance card. If there is ever a question, they certainly have the ability to pick up the phone and call the prescribing physician to double check that this is a legitimate prescription. But there really isn't any other ability for the pharmacy to check. But one of the things we've been developing at Copernicus is attaching an iris scan to the actual prescription, so
So
that
that's in line with what I'm talking about.
right, exactly. It's not a biomarker for the drug to see if the patient would respond, but it's a way for the pharmacy to have the ability to intervene with not necessarily knowing that the license that you're showing them is their license, and it's a way to try to limit groups of people who go around from urgent care center to urgent care center receiving narcotic prescriptions, going in and getting them filled in that city, getting back in their van, driving an hour, going to another pill mill. And one of the issues that we haven't really discussed with the PDMP is that there's a 24-hour lag, so that if you go to 5 pharmacies on the same day, you can get 5 different prescriptions filled. The idea behind attaching an iris scan to the actual prescription is that, number one, we don't need any other patient information, so there's no chance of any type of HIPAA violations. And number two, we think that it may be a deterrent for the nefarious drug seekers.
Right. As you were describing that, I'm thinking, well, if I'm one of those folks that's kind of in the business of opioids, I'm probably going to possess more than one ID, so I can maybe skirt an issue like what I was talking about with my antihistamine. But what you're talking about is something that's tied to the human. It's a biomarker. It's iris number 13457 that I also know this iris just happened to 20 minutes ago also present and was scanned at a Walgreens down the street. Is that what you're talking about?
Yes, sir. And so for our platform, it would be in real time, so there would not be any lag, and it could easily be across state lines. The other point is patients who are truly chronic pain patients who are just coming to get their monthly prescription filled, number one, they wouldn't be flagged, and number two, they don't mind giving their iris scan.
Well, that makes sense. I mean, where is something like that in its development? I mean, is it how far out of the horizon are we talking about to be able to do something like that?
Well, we have the technology now to do it, and it's very appealing because it just gives yet another point. We heard several different ways that physicians would be able to intervene. The 60 Minutes segment showed that there may be some roadblocks for the DEA on a distributor scale, but this would give the pharmacies an ability to intervene as well.
It seems like that's a good spot to do it, just like they worry that I'm going to go home and make meth with my Claritin D. Obviously, making sure that I'm just presenting to pick up a prescription as it was ordered by Dr. Lundy for my broken leg, rather than, oh, I see you've also visited 3 other sites today.
Well, I'll ask the rest of the panel, and obviously it's what technology has is amazing, right? First of all, are there any other technological advances that you are aware of or participating in that can assist in it? But from my perspective, when I hear Dr. Shaver speak, number one, the idea of someone who has nefarious intent converting a legal prescription into illicit, means, and going back to what Dr. Lundy said, I firmly believe that someone who is addicted and getting prescription drugs are not the people selling them. They may use illicit means to grab more drugs to feed their addiction, but those aren't the people that are selling them. The people who are selling them are people who grab a recruiter that grabs a bus full of people, gets in a van, drives to 3 states, picks up 20,000 tablets, and goes back to their distribution point, wherever that may be, and converts those legal prescriptions into an illicit means. And one of the things that I actually wrote an article on last month was, when did we believe or expect our physicians to become trained in law enforcement? You can't tell me if a fake ID is fake. I can't tell you if a fake ID is fake. And it's all of a sudden now it's, you need to be a trained law enforcement officer. You have to, spot fake identity and it goes away from care. But maybe you guys can comment on some of that of, from the Attorney General's perspective or law enforcement. Do you think that somebody would give you a scan if they're a criminal? Do you think that they would believe that when you tell them, no, there's no PII data, there's no HIPAA data, all we care about is a prescription, they're going to go, oh, okay, scan my iris?
Well, yeah. Well, at the thought of it sounds absurd, just as you mentioned. But at first thought, Attorney General Carr said it. If there are those that wish to violate the law in such practices, I mean, maybe something needs to be done. And again, from our perspective within our boundaries and, you know, who we prosecute in terms of who we litigate, our statewide partners in terms of local law enforcement, DAs and of such, we offer the opportunity and partner with them to kind of trickle down on this.
Yeah, I would say just as it relates to the physicians, I think the biggest challenge, and I agree with you, they're not trained in law enforcement, they're in medicine. I would say that the challenge that they have is having the most up-to-date information available. And that's the real challenge, because the PDMP is a great tool. However, as you mentioned, it takes 24 hours to get that information in there, and there's probably another 24 hours. So you got about 48 hours in real, you know, in actual time before the next pharmacy can pick it up or the physician can pick it up. One of the things that you've had in some states with some success, other states not so much, are health information networks. So in 2009, money came down from the federal government to develop health information exchanges, for lack of a better term. And what they were supposed to do is that those exchanges were supposed to compensate for the lack of interoperability with all the EMRs. And so if you have one EMR and a physician has another EMR, well, they don't talk, right? If the hospital's on one and whatever. And also all the EMRs say that it's proprietary, so they don't want to have interoperability, right?
Right.
And what they're showing is that the EMR companies do make a substantial profit off the interfaces that are required if you want two different EMRs to speak to one another. So in Georgia, we have the Georgia Health Information Network, and they're doing a good job. And you've got regional health information organizations that connect to the Georgia Health Information Network. Kind of, it's a highway of highways, right? Think about an interstate with entrance and exit ramps. Now, the issue that you run into with it is that it's getting all the physicians and the providers onto this network, and so the challenges that you're having is the interfaces, because for physician practice to have this interface to get onto this highway costs anywhere between $5,000 to $15,000. Okay, so that's a big hit for a small practice. Okay, so if you don't have that connectivity, then you're not going to get the real-time information. So by way of an example, patient goes to one physician's office, gets a prescription, they enter that into the medical record. Then if they go a couple hours later to another physician to get more pain medication, and if they're all on the health information network, then it automatically gets into the cloud, and so it's real time. So then the use of a PDMP, the benefits become a little bit less, although it's still relevant, but it really becomes this interconnectivity. So that's the challenge that we're nowhere near that right now, Georgia. You've got only about maybe 10% of the physicians in the state that are on a health information exchange, mainly because of the cost.
So I'll present this to Representative Beskin and anyone else in the panel, but I'll start with you with this question, and I appreciate that comment. And I believe, coming from technology, you know, it really real time is all that matters, right? But when we look at the opioid problem specifically, as far as the conversion from a prescription drug to an illicitly obtained drug, and one of the things that just intrigues me about that whole iris technology or a technology is, first of all, people who are getting nefarious prescriptions aren't using payers. There's no payer attached. It's a cash transaction. So there is no way to trace it through a payer. Number two, you could probably say with most certainty that they're not using their real identity or their real name. So being able to access records for someone who has nefarious intent walking in doesn't really help us stop this issue. And so from a state level, is the state involved in any technology either like that or similar? Or because, again, I think that criminal or demonizing physicians or demonizing physician groups or demonizing hospitals, we treat pain with drugs and it's necessary, as Dr. Lundy said. But all of the tools that we seem to have with health records are geared towards people who have payers attached and who have chronic illnesses. And the source of this problem, in my humble opinion, I will say that it's not those people. It's those people who are utilizing the loopholes in the system to go to pill mills and to get robo-prescriptions signed. And that's data that doesn't even exist because they're using different names every time. There's no analytics to apply to it. So is there a solution that you're aware of that can kind of combat that? Or is there something at law enforcement that can be done? Maybe you can share with us.
That was a long question, multifaceted. I do think it's a law enforcement problem, but starting back with how the discussion started about iris scans, I was really interested in speaking with Dr. Shaver about this before this panel got started because we were talking about this technology, and we've heard about this, either retina scan or iris scans, for a long time now, and some people are scared by that. And I said, well, where else is that being applied or utilized right now, if any? And the one example that we talked about was the CLEAR global entry program when you pass from one country to another. So apparently that is scanning what, Dr. Shaver, your retinas?
Yes.
And this is talking about an iris scan. So it is a new technology, but you're right. You're talking about the drugs that are on the street. Some were gotten legally, some were gotten illegally, and some are not legal drugs, like this whole problem we had a couple of months ago with the fake Percocet in Macon. So if the criminals cannot get enough legal drugs, meaning these excess prescriptions that are sitting around in people's medicine cabinets or whatever, they're just going to go to China and buy some that are stamped Percocet, and who the heck even knows what that is? That's fentanyl or whatever. It's terrible. Those are law enforcement issues.
Would you say we're doing a better job combating that issue of the importation of drugs than we are of controlling opioids that are legally produced and legally distributed? That's the question.
It seems that we have fewer pirated drugs because there's such a prevalence of readily available, legally prescribed, quality controlled drugs. Right. They're called medicine if you get a prescription for it. It's drugs if you get it illicitly.
You bring up a great point on that. It's, once again, what are we trying to fix here? The issue seems to get completely confused and very quickly, and it all tries to fall under one entire problem with this opioid crisis. And even when the legislature was debating it, I mean, heroin kept coming up, and I don't know about you, Dr. Schaefer, I've never written a prescription for heroin or anything like that. So how did heroin, I mean, I understand the link between, it says opioids are the gateway into heroin abuse. Got it. But let's focus on what we're talking about. And what you brought up earlier specifically was the diversion of legal prescriptions, people shopping doctors to get prescriptions illegally. They're getting them under nefarious purposes to illegally export the drugs. We've talked about the chronic pain patient that may get in over their head and for whatever reason overdose, the acute pain patient that could overdose on the pills, and as well as somebody who comes to somebody's house and rummages through their medicine cabinet. And there's those many different issues, and the legislation that we're familiar with doesn't seem to target any one of those four problems very well, at least big holes, and I will go as far as say injured patients in those different categories that get hurt by the unintended consequences of the legislation or the rules. And so I think that this needs to be a much more focused effort and focus on what the actual problem is. And I'm still not sure I've seen it yet. Is the problem coming from the medicine cabinets in my house? When my kids' friends come over and go through there and take something from there, if that's the problem, then we as physicians can adjust our prescribing habits for that. But it seems like it's just getting blasted on everything.
Well, I know, and you brought up the case with Clear as far as how that type of technology is being used. I think one of the problems is walking that very fine line between the patient and their need to their privacy issues, which is HIPAA related, and then the need to combat this issue. And I think one of the problems that I saw when Dr. Shaver and I talked about the solution that the software is presenting is there has to be a database attached to Clear. There has to be a name and address, a phone number, a copy of a driver's license, a copy of a passport. And the reality is, if that database is hacked, and unfortunately with the Equifax issue, we're all dealing with that knowledge of it can happen to any of us any day. There's valuable data in there. And Dr. Shaver, I know when we spoke about this, there really is no patient identification. It's really just a prescription that gets appended with a scan. So you don't really care who the patient is,
correct,
or where they live, or what their name is, or what their treatment is for. All you care is, I'm sorry, forgive me, oxycodone is prescribed at 2.5 milligrams, whatever the prescription says, for however many days, and it got picked up on this date. Is that correct?
Yes.
So let me ask you this: would you scan your iris to get a legal prescription if they asked you to?
I would.
Would you?
Absolutely.
Would you?
I would.
Would you?
Of course.
Do you think a drug? I mean, so I think that the intriguing thing about this is kind of like when someone asks for a thumbprint at a bank. If it's a fake check and they see that stamp there, they're probably going to turn around and walk out.
Right.
Right. So then the question becomes, does the ability to have a deterrent attached, Because I know if I'm in pain, as you said, like I got surgery or I'm in pain and I need a prescription, I don't care what you need from me. My doctor prescribed it. I need my painkiller or I need my antibiotic or whatever's going to make me well again.
Right.
There's no concern there. But I'll ask you, leading back to your answer to the question, that balance between managing the patient, their privacy, and treating the patient, at what point does it shift from the burden being on you to police it, to govern it? See, I'll tell you one of the problems that I had, and I've read the PDMP, the legislation pretty thoroughly. What's going to stop me as a physician to start writing prescriptions under 28 days? There's 4 categories
Right.
that as a physician, and in the problem that I look at and say, well, what did we miss? There's no ending to the story. I'm going online and I'm looking up to see if you got a prescription previously, but I don't have to enter my prescription in right away, or I have 24 hours to wait, or I can just write a prescription for under 28 days, and now I've met the requirement. I don't have to report it. So when does that shift from the patient or from the practice of the practitioner to somebody else in the chain to allow you to treat patients again? Because in the law, it specifically states that if you do see that a prescription was had yesterday, it's up to your discretion as a practitioner whether or not you prescribe again or release that prescription. Am I right?
That's right. And one of the issues that we have with this is the what's next. Yeah, just because it says that, and the first iteration of the law, as Donald brought up, where it was criminal charges associated with failure to assess the PDMP and do that, we're a little wary of this. And so, to your point, yeah, it's 28 days, but how exactly do we calculate the 28 days, and where do I fall back in line into some kind of loophole where I can get hit on this?
Right.
And
And let me address the privacy issue that you brought up with the iris scans. Back in 2008, 9, 10, when the original PDMP bill was going through the legislature, one of the big issues back then was the concern about privacy. And rightly so. PDMPs were relatively new, coming onto the scene in the early 2000s. Georgia was kind of in the middle of the pack at the time of passing for a law with PDMP. And over time, the privacy issue has somewhat subsided as people became more informed about the PDMP and also developed more of a comfort level. And so I would say that to answer your question with regard to the iris scans, yes, there's some privacy issues that are associated with it, but I think the more that people become comfortable with the technology and understanding that it's being used for a specific purpose and not for any kind of nefarious purpose, you will get to that point. But it's just an education, and it's just a comfort level that eventually gets there.
Sure.
I see your point, though, with the iris scanning, because I have Clear when I fly. But I don't have to do Clear. I can go through pre-check. I could go through. But once again, I am showing my license and all the other things. But I do prefer the convenience of Clear, of just dropping my eyes or my fingerprints on the scanner and going to the front of the line. When it comes to prescription opioids, it's not. To some degree, yeah, you can survive without it, but it's not a convenience thing.
Right.
If you've got a femoral fracture and you're in a lot of pain, it's not really I could have taken pre-check and gone, no, it's kind of, how do I get through the day without, white knuckling the bed,
And just like we have some exceptions in the PDMP for don't have to report in case of palliative care or advanced cancer treatment patients, those in hospitals, maybe it would just apply to an outpatient prescription, an office visit or a surgical center or whatever. And it occurred to me, something I think one of the physicians said, maybe Dr. Shaver, is that some patients actually know what they want. They know their medicine of choice, their milligram dosage or whatever, and that kind of alerts you that this person may be dependent on this medication. And it's occurred to me that those same people might study and understand the PDMP. So when they go to have outpatient surgery, they might go, hey, doc, why don't you write that for less than 10 days and fewer than 40 pills? Knowing that wouldn't be reported, and that might alert physicians to this might be somebody who has a history of abuse.
And then also the medical board, the Georgia Composite Medical Board, passed a rule this past summer that said that every physician that has a DEA license is required to take 3 hours of CME on opioids. And so I think some of those issues are starting to be addressed. But the one challenge with that law is that if you don't prescribe opioids on a regular basis, like if you're an ophthalmologist and you may prescribe it 2 times a year, you're still impacted by that law. So as long as you have a DEA license, you are required to take that CME even though it may not be as applicable to your practice.
You know, we have two surgeons on the panel, and so I guess we have a significant bias with that. My perception of where this comes into is in the patient that we've been prescribing opioids for a prolonged period of time from an injury or whatever they have in the past, that we just keep going on. And I think that the law that really helped us escort these patients out of our acute surgical practices into pain management practices, where those prescribers are far more capable of detecting a lot of things that Representative Beskin brought up and trying to affect those changes in those individuals.
And then also the Georgia Composite Medical Board also has rules and regulations that say that if a patient's on narcotics basically 90 days, then there has to be urine tests, saliva tests, something along just to continue to check that patient. So there are a lot of rules and regulations as well as statutes that have been passed since 2011 addressing this crisis. I think one of the challenges, and it's you know, because when you've got an epidemic as it is, everybody's constantly trying to find a solution. We've got to wait for some of these the solutions that have been passed to play themselves out before jumping to the next solution. It's almost like a scattered shot versus a strategic approach. And I think there just needs to be more of a strategic approach. But I tell you this, I am optimistic because in 2010, these weren't the conversations that were happening. I think getting more and more different groups and interested stakeholders around the table is moving this towards a solution, but I think also people are becoming more educated. I think once it really started to hit the national news, you know, it really got on people's radar to really start addressing this issue. So I am optimistic on where we're going with this, that iris scans are being discussed. And I mean, it's you know, you don't get to that solution unless you really start, you have a real need for it. So thank you all for all the work that y'all are doing on this as well, and as well as everybody here.
Well said.
I mean, the takeaway obviously is that when you put, as you said, stakeholders and obviously, you know, surgeons and physicians who are in the trenches and dealing with this every day, and obviously thank you, Representative Beskin, because your trenches are a little different. You weigh the benefits of what the citizens of the state are, and also trying to manage how you can help physicians and hospitals and treat our citizens better as patients. I always believe that technology is exponential, right? What used to take 20 years, like what took us to get from 1985 to 2005, now takes a couple of months. And so I'm excited about the ability to take healthcare and really bring it to a level where the technology that's utilized in retail, in the airport, or that can obviously be applied to what we do every day as practitioners, and then more importantly, the benefits for law enforcement. Because I know one of the things that CW and I talked about was, wouldn't the state attorney general or the DEA or the GBI like to know if you have a pharmacy that's not scanning irises, why aren't they? Or why are they not collecting driver's license when they're supposed to? Or wouldn't you like to have a report that there's somebody that just went to 7 pharmacies in 30 minutes? And those are the kind of reporting that can kind of clamp down on this and not just rely on the deterrence, and then, you know, with everything that's out there, there's so many companies in the medical space that have technology. I'm sorry, you can't tell me that we can't find a solution. Practically no one's making methamphetamine in their bathtub anymore, right? And what did that take? It took taking pseudoephedrine from in front of the counter and putting it behind the counter. And I believe that really was the major contribution. So hopefully we can continue discussions like this. And I certainly appreciate being a part of it, but everyone that came today and taking your valuable time up to, you know, just try and serve up some opportunities. And we're going to be doing this, CW and I, monthly. So you will get an invite back, obviously, and we certainly appreciate it. And CW.
To the panel, do you have any sort of websites or resources of information that folks might want to check out? If you can, we can throw them out there. If not, we'll wrap.
I would say www.mag.org. Under that, we have our MAG Foundation on that website, and it gives summaries of House Bill 249, but also our Think About It campaign, also Project Dan, all that we're doing to addressing prescription drug abuse.
And for us, www.law.gi.gov. If you're interested in being involved in the statewide task force, that's where you could go to find updates about the meeting minutes and when our next meeting will be taking place. And we're also involved with MAG and the Think About It campaigns and a few others that's taking place.
There's a website sponsored by the National Conference of State Legislatures. It's www.ncsl.org/documents/health/pain management 216, and that's where one can go to see what is going on with across this country with efforts to address the opioid epidemic.
And we'll be posting, excuse me, all of these links that you've had will be posted on opioidepidemicsolution.com for MAG and for the Foundation, for the Attorney General, so that people will be able to access this after today's webcast and to be able to see really the progression. We're committed to, CW and I are committed to assisting and finding a solution. I don't think there's anyone who's untouched by this, so we certainly appreciate everyone's participation. And CW, I'll turn it over to you to close out.
Well, if you've not done so already, you can go out to iHeartRadio under their podcast section, look up the Executive Roundtable, follow us there. That way, each time we put out a new episode, it's alerting you, and you can check it out when it's convenient for you, when it's available. We hope you turn around and click share. This, I can assure you, you know somebody that's dealing with this in some form or fashion, whether they're physicians that are dealing with this from the point of care, or patients themselves who have gone through the process and experienced some issues around consumption of opioids themselves. It affects many, many people. So if you can click share and get more people thinking about this and engaged in this conversation, I think we can possibly lead to a solution. So everybody here, I know that you're very busy people, and I really appreciate you making time to sit with us at this table. And I look forward to getting into other topics around this. I mean, we could benefit from maybe hearing from addiction specialists as well, for example, to see what, if any, kind of resources are available from those folks if they get to that point. So I just want to say thanks to Dawn and CopernicusMD for being a partner in this program, helping to make it available. And to all my guests, thank you very much. I appreciate it.
Thank you.
Thank you all.
Everybody out there who made us a part of your day today, thanks so much, man. We'll look forward to catching up with you next time. We'll see you then.
Thanks so much for doing
Thank
this.
you all.
That was really,
No, thank you.
really great.
No, absolutely.
Coming in.